I'm about to reveal something that might shock you about the burning electric pain shooting down your leg right now. I'm Dr. Emma Whitmore, and after 3 decades as a spinal surgeon, after cutting into thousands of lumbar spines, after holding degenerated discs in my hands and seeing sciatic nerves flattened like crushed cables, I can tell you with absolute certainty that almost everything you've been told about sciatica is wrong. You've been told it's just wear and tear, that it's your age, that you need stronger painkillers, another injection, maybe surgery. Except that explanation is incomplete, it's outdated, and it's keeping you trapped in pain. The truth is far more mechanical, far more precise, and far more reversible than you've ever been told. And what I'm about to show you could literally save you from a lifetime of disability. Margaret was 72 when she came to see me, a retired school teacher, walked 2 miles a day, took her blood pressure medication faithfully for 15 years. Her MRI showed a mild L4-L5 disc bulge, nothing dramatic, nothing that screamed catastrophe. Her doctor told her to rest, prescribed 600 milligrams of ibuprofen 3 times daily, and reassured her it would settle down. Instead, the pain intensified. Shooting, burning, wrapping from her lower back through her right buttock and down to her calf. Her leg began to tingle. Then it weakened. She fell in her kitchen one morning because her foot simply didn't respond. A fractured wrist, 6 weeks in a brace, all because her sciatic nerve was being compressed and strangled like a garden hose, bent at a sharp angle. Here's what most doctors never explain. Your sciatic nerve is not just a wire sending pain signals, it's a living cable, wrapped in protective layers, designed to glide and slide through muscle and connective tissue every time you move. Imagine it like a thick electrical cord running through a series of tunnels. If one tunnel narrows, because a disc bulges backward, or a deep muscle like the piriformis tightens, the cord doesn't just sit there politely. It gets trapped, inflamed, irritated, and every step you take becomes friction against a sensitive structure. Under the microscope, I see swelling. I see inflammatory proteins bathing that nerve root. I see reduced blood flow. First comes chemical irritation. Second comes mechanical compression. Third comes muscle inhibition, where your brain literally shuts down strength to protect you. That's when falls happen. That's when independence disappears. Comment below and tell me your age and how far your pain travels, just to the thigh or all the way to the foot. Because the distance matters. By the end of this series, you're going to understand exactly why that nerve is screaming and what precise movements can free it. Not manage it, not mask it, free it. But before I reveal the exact sequence that changes everything, you need to understand the first hidden mechanism most physicians completely overlook. Here's where we go deeper, because if you don't understand the biology, you'll never take these movements seriously. Remember that electrical cord running through tunnels? Now imagine one of those tunnels is made of muscle, the piriformis, lying deep in your buttock, sometimes directly over the sciatic nerve itself. In nearly 17% of people, anatomical studies show the nerve actually passes through that muscle. Through it, not around it. When that muscle tightens from prolonged sitting, reduced hip rotation, or age-related stiffness, it clamps down like a fist. First, the muscle fibers shorten. Second, local inflammation increases cytokines and substance P around the nerve. Third, microvascular blood flow to the nerve decreases. Nerves are greedy for oxygen. Starve them, and they protest with fire. That's why the figure 4 piriformis stretch works when done correctly. It's not just stretching, it's mechanically increasing the diameter of that muscular tunnel. When you lie on your back, cross one ankle over the opposite knee and gently draw the supporting leg toward your chest, you externally rotate the hip. That rotation lengthens the piriformis. As it lengthens, pressure on the nerve decreases millimeter by millimeter. Under imaging, we see improved space. Clinically, patients report reduced leg radiation within weeks. Thomas was 68 when I evaluated him. Former accountant, sat 10 hours a day for decades. He'd been on naproxen 500 milligrams twice daily for 8 months. His pain radiated to his ankle, 8 out of 10 intensity. MRI showed only minimal disc protrusion. But palpation of his piriformis reproduced his exact leg pain. He began a controlled figure 4 stretch daily, 30 seconds per repetition, 5 repetitions per side, twice per day. Within 4 weeks, his pain dropped to 3 out of 10. Within 8 weeks, he was walking a mile again. No injections, no surgery. Comment tight if you sit more than 6 hours a day, because prolonged sitting is gasoline on this fire. Now let's talk about the second overlooked mechanism, nerve mobility. Peripheral nerves are designed to glide like a train moving smoothly along tracks, but after inflammation, scar tissue can tether the nerve. Think of it like gum stuck to the tracks. When you move, instead of sliding, the nerve stretches excessively at one point. That creates tension, which increases mechanosensitivity. The sciatic nerve glide, coordinating knee extension with neck flexion, then reversing, creates a rhythmic tension and release along the entire nerve. Not a static stretch, a pump. First tension increases, then it decreases. This oscillation improves intraneural blood flow and reduces adhesions. A study published in the Journal of Orthopedic and Sports Physical Therapy followed patients performing nerve glides for 6 weeks and documented significant reductions in pain scores and measurable increases in straight leg raise range. Not a small change, a clinically meaningful one. If you feel tingling when you straighten your leg, comment glide below, because what you're feeling isn't random, it's mechanical. But there's a third mechanism, disc-related compression, that we haven't fully exposed yet. And this is where most people get it catastrophically wrong. Now we address the third mechanism, and this is the one that terrifies people because it involves the word disc. When I look at an MRI and see a posterior disc bulge at L5S1, what I'm seeing is not just wear and tear, I'm seeing a hydraulic system under pressure. Your spinal discs are like jelly-filled cushions between vertebrae. The outer ring, the annulus fibrosus, is made of layered collagen fibers. The inner core, the nucleus pulposus, is gelatinous, water-rich, designed to absorb shock. But when you sit hunched forward for years, when extension disappears from your daily movement, pressure shifts backward. Imagine squeezing a jelly donut from the front. Where does the filling go? Backward, toward the nerve root. That posterior migration creates chemical irritation first. Nucleus material contains inflammatory mediators like phospholipase A2, then mechanical compression second. That's when pain shoots below the knee. That's when weakness begins. Harold was 75 when this exact pattern nearly cost him his mobility. His pain radiated to his foot, 9 out of 10 intensity. He had been told to rest and avoid bending backward. For 3 months, he avoided extension entirely. His MRI showed a moderate L5S1 protrusion. But here's what changed everything. Repeated spinal extension, the Mackenzie movement developed by Robin Mackenzie, lying prone, pressing his upper body upward while keeping hips grounded, 10 repetitions every 2 hours. Within 10 days, his leg pain began to centralize. That word matters. Centralization means the pain moves from the calf to the thigh, from the thigh to the buttock, and finally back toward the lower back. It's not worsening, it's retreating. It's the nerve decompressing. A study in Spine Journal demonstrated that patients who experienced centralization with repeated extension had dramatically better long-term outcomes compared to those who did not. Not a minor difference. A predictive one. Comment centralize if your pain sometimes retreats closer to your back, because that's a powerful sign. Now I'm going to start giving you specific actions, but stay with me. First, daily piriformis stretching, controlled, moderate intensity, never ballistic. Second, seated sciatic nerve glides, 10 to 15 rhythmic repetitions, 2 to 3 times daily. Third, repeated extension if your symptoms improve with it, performed consistently, not randomly. If extension drives pain further down the leg, You may require a flexion-biased alternative, but most disc-related patterns respond to extension when done correctly and repeatedly. The key is frequency. Discs respond to repeated directional loading, like clay being reshaped gradually, not forced once. Comment frequency if you understand that repetition matters more than intensity. This is not about aggressive stretching. It's about mechanical remodeling. And I'm going to give you the complete protocol: exact repetitions, timing, progression, how to know if it's working within 7 days, and what to do if your doctor dismisses this approach. Because this is reversible, not in theory, in practice. Now I'm going to give you the complete protocol, and I need you to listen carefully because precision is everything. First component, the Figure 4 piriformis stretch. Lie on your back, cross one ankle over the opposite knee. Draw the supporting leg toward your chest until you feel moderate tension deep in the buttock, not sharp pain. Hold 30 seconds, 5 repetitions per side, twice daily. No bouncing. Controlled breathing. Second component, seated sciatic nerve glides. Sit tall, extend one knee while flexing your neck forward, then lower the leg as you lift your head. That coordinated tension and release is 1 repetition. Perform 15 repetitions per leg, 3 sessions per day. It should feel like a gentle pull, not a sustained burn. Third component, Mackenzie extension. Lie prone, press your chest upward while hips remain in contact with the floor. 10 repetitions every 2 hours while awake for the first 7 days. Yes, every 2 hours. Frequency reshapes discs like steady pressure reshapes clay. If your pain centralizes within a week, you're on the right track. If it peripheralizes, meaning it travels further down the leg, stop extension and reassess directional preference. Eleanor was 79 when she began this exact sequence. Her pain had radiated to her ankle for 6 months. She was scheduled for an epidural injection. Within 14 days of consistent repetition, her pain retreated to her buttock. By week 4, she was walking half a mile without support. At 3 months, she cancelled the injection. Her MRI 6 months later showed reduced disc protrusion. Not magic, mechanics. Now, objections. But my doctor says I need injections. Bring the research. Show them outcome data demonstrating that directional exercise with centralization predicts superior long-term function. Most physicians respect evidence, some won't. If they refuse to consider mechanical loading principles, seek one who does. This is too time-consuming. Then you're not serious about keeping your independence. Surgery costs tens of thousands of dollars. Loss of mobility costs your freedom. These movements cost minutes. Cheapest insurance you can buy. Can't I just rest? No. Discs and nerves deteriorate with immobility. They require graded motion, not bed rest. Motion. Comment commit if you'll perform this protocol daily for the next 14 days. Subscribe to this channel right now because the algorithm only shows this to people who engage. If you don't subscribe, you may never see the next strategy that protects aging spines. Your subscription could save someone from a fall. Leave a comment with your age and where your pain stops: thigh, calf, or foot. Every comment tells YouTube this matters. Share this video with anyone over 60 who complains of leg pain. Somewhere right now, someone is being told to simply live with it. This could change that. I've created a detailed mobility blueprint expanding this protocol step by step. Click the link in the description and join the newsletter to receive it first. Bookmark this video, return to it, track your progress, and before you leave, watch my next video on preventing spinal stenosis progression, because freeing the nerve is only the beginning. You now understand the mechanism, you now have the tools, use them.